Hello, everybody. Thanks and welcome to this episode of our podcast. We have again with us our guest, Dr. Andonis Terezides. Introduced you at the last podcast about the bisphosphonate medications. Today, our episode is about blood thinners. You're obviously an oral surgeon, and I think if you didn't like blood, there would be a problem. I think you deal with blood all the time. And so bravo for you. I'm glad somebody has a stomach for it. A lot of people are very glad that you're there. So the reason I want to talk about blood thinners is because there's been a lot of changes. I know I see legal ads. Every time there's 10 new legal ads on the news, you know there's some new drug. I see, have you been on this blood thinner, and has somebody known somebody who died from this blood thinner? And so immediately I called you and said, hey, what's going on with blood thinners? And you told me all the stuff, and I think the world needs to know about it. The basic premise is there's a bunch of new blood thinners out. I want you to tell people who are generally on blood thinners, what are they getting treated for? Obviously, they're important for what they get treated for, but they do provide you with roadblocks when you're doing surgery. So some of the newer blood thinners, what are the pros and cons of them? So please tell us a little bit about, introduce to us what are most patients on blood thinners for?
Well, Ramzi, in the last 5 years, there's been an explosion of new medications on the market, and many of those have been what we call these blood thinners. And they work a little bit differently than many of the traditional medications patients that would have been taken. For instance, warfarin or Coumadin is a very common one that many patients have been taking now for 50 or 60 years. Mm-hmm. Aspirin is one as well that patients have been taking for probably more than 50 or 60 years as well. And then over the last 30 years or so, patients have been taking something called Plavix or clopidogrel. Yes. Mm-hmm. These are the three most common ones, the ones that we're most used to, and we've kind of developed our patterns of how to treat patients, and we know what procedures we can do, what procedures we can't do, and how we would modify them. But over the last 5 years, there's been really an explosion of new medications, and their studies are lacking in a lot of the literature of what we need to do from a dental standpoint. You know, they've really only gone into the thing of major surgical procedures in a lot of the literature, and that kind of leaves the smaller procedures in limbo of what we can and can't do safely for patients. So really what's also prompted the attorneys now. You know, they've got a new field of medications that they can drive new business from.
Sure. So who are these people that are on them? What are most patients out there on blood thinners for?
Well, they're on there for the same reasons that they've been on before, and that's for cardiac stents, which are the coronary artery stents that patients have placed sometimes after angioplasty if they've suffered a heart attack or a coronary event. They're on them also for stents that sometimes get placed into the carotid arteries because of plaques and risks of stroke. They get placed on these medications as well for reasons such as deep vein thrombosis or blood clots in the legs and the extremities, which are at risk for causing something called pulmonary embolism. And then they're also on these medications because they might have suffered a stroke in the past because of one of these pulmonary emboli or DVTs has traveled up to the brain.
Oh, wow, okay. So most people that are on blood thinners, they know they're on blood thinners. It's no secret per se.
Right.
Okay, so things like aspirin and Plavix, I mean, yes, we see these all the time. Do these really, if somebody comes into you and they're on aspirin, do you have to stop the aspirin or Plavix for that matter, or what do you do with those?
I'll tell you, for routine things that I do as an oral surgeon on a day-to-day basis in the office, like place dental implants, perform bone grafts, or take out teeth, I don't stop patients from those medications.
Okay.
There are times when I'll have to have them modify their regimen somehow, or at least check some lab tests to begin with so that we know that they're within a safe range before proceeding with the surgery. Aspirin and Plavix we rarely ever stop, and there's no real tests that we perform prior to surgery. We just gauge it based on knowledge of what local measures are available to us to help with stopping the bleeding during
like stitches and stuff like that.
Stitches and little things that we can put into the sockets, etc., as well as good surgical technique. And then there is one medication that they're commonly on, like we talked about, Coumadin, or also called warfarin. That one we do test some lab tests, and we like to have lab values within 24 hours of the procedure. It's a blood test called an INR, and patients are very familiar with it because they do it anywhere from 2 to 4 times a month to make sure that they're within a therapeutic range for their procedure.
Oh, I see. Okay, so
But
people.
the
So
newer
okay.
medications that we're talking about, things like called Pradaxa, which is dabigatran, Xarelto, which is rivaroxaban, Ticlet, which is ticlopidine, Pletol, which is cilostatazole, Persentine, which is dipyridamole, Effient, Prasugrel, Brilinta, which is ticagrelor, and Eliquis, which is apixaban, which see very, very kind of convoluted names.
I remember seeing
Very easy for
Eliquis on
patients
the.
to not remember them and just to say, oh, I take aspirin or I take one of these medications that, that I'm on a blood thinner, but I don't remember which one. Now that list of 3 has grown to a list of 8 or 9, and there's even more still coming on the market. And now we're at a point where we don't know what to necessarily do because we don't know how to test these medications. Some of these medications don't have reversals, and the doses are the same for patients. So a 110-pound lady and a 250-pound guy are taking the same dose of medication, so we don't really know how they're going to react and if they're going to be the same.
Do these new class, I mean, they're obviously coming out in the market for a reason. Are they better for the people with atrial fibrillation or stents or blood? I mean, they must be coming out because they're medically better. I realize that from your perspective as an oral surgeon, it presents challenges. But are they better somehow when patients are taking them?
But that's what the initial studies in the literature are showing, and part of it is that some patients are not really responding as well, let's say, to the Coumadin or to the medications that they take. They're all usually going to be okay with aspirin, but some patients are allergic to aspirin, let's say.
Okay.
Some patients require some sort of dual platelet therapy like aspirin and Plavix. And there is a subset of population of patients, I think I read in the literature, about 20 to 30% of patients don't necessarily receive the appropriate anticoagulation that they need. And so there is a need on the market to find a better medication, maybe one that's less hassle for a patient to not have to go and give blood and have it tested all the time to stay within a therapeutic range. So yes, the hope is, and that the studies are showing that most of these medications do serve a better purpose for many patients who were not so well served with the old-fashioned medications that we're used to.
The classic ones. So tell me this then. So we have the classic blood thinners, Plavix, Coumadin, aspirin. You have some patients, 20, 30%, for whatever reason, it's not well regulated. They can't do the INR. They want something a little easier to take. So there's this whole new list of medications coming out, Pradaxa, Eliquis. Those are the ones I've seen personally. So how do you manage that? What do you do as an oral surgeon? Somebody comes into you, yes, I'm on Pradaxa. I need a tooth out, and it's hurting. What do you do?
Well, single tooth, we'll probably just continue them on their medications the way they are. Again, a lot of these medications cannot be stopped. If you stop them, even for a day or two, it puts the patient at significant risk for ending up in the hospital, and a significant number of those patients can actually succumb to the sequelae of stopping the medications and can die. So fortunately, as surgeons, we're able to do procedures relatively quick. We have at our disposal a number of things which can help us provide electrocautery or some sort of localized measure to get hemostasis to stop any bleeding. So for most of the routine things that we would treat a patient, if they're stable enough to be treated in our office, we can proceed as planned. If we come across that one patient that is on these medications and they've been on it for whatever reasons, they're not able to stop the medications because they've been changed onto a different medication because they're only within a certain subset of time following new placement of a new cardiac stent that was done only a few weeks prior, and it has to be done, we have the luxury as surgeons to be able to take a patient to the hospital and at least get them managed in an operating room setting.
Oh, that's like the end of the line for you as a surgeon. I mean, I can't go to the hospital clearly, but as an oral surgeon, hey, we have a high-risk patient. He has a tooth that's hurting. It's infected, whatever. I got to do surgery. You can manage it in the hospital. Clearly, that's the last choice you have. But, so it sounds like it's still a little bit early. The jury's still out on these new medications. Yeah. And, while they're great for, I'm sure, cardiologists love them and all the other MDs love them, good, that's great. But from a dental point of view, it does present some challenges that need to still be worked out. But I'm glad there's people like you that love this stuff. You're a complete dental geek. You love it. I know you're reading about it all the time. When I asked you to do this, you sent me like a 5-page paper on what we could talk about. I didn't even know how to pronounce 60% of the words. So I'm glad there's people like you on my team. So Dr. Terezides,
I'm happy to do so, Ramzi. I just want to make it a point for your viewers who are watching this that they should never stop any of their blood thinners without the express written written consent and knowledge of their prescribing physician. There's a lot of times when patients will come because of the old school mentality where they would just stop their aspirin for a few days before or something before coming in to get a tooth taken out. You know, we've really, as a profession, dentistry as a whole, we've moved away from that because we've learned that we can treat patients without necessarily having a lot of serious issues while they're still on their blood thinners, which is actually much more important because we can deal with a little bit of bleeding, but we really can't deal with a patient who suffers a stroke or a heart attack as a result of stopping the medication.
Wow.
So really that's the biggest take-home message is patients need to be able to give us their medication list clearly, have something written down or at least give us the contact information for their prescribing physician, and then that they shouldn't stop the medications. If we can do that, we can provide an excellent service for patients.
Yeah, I had no idea that you've had patients come to you say, hey, by the way, I stopped my medication 3 days ago. I'm ready for surgery. And you're like panicking that they're going to have a stroke in your chair. I didn't even think about that. But yeah, anybody watching this, please get to your physician, get to your oral surgeon, tell them what's going on, let them manage it. Don't start doing this at-home cookbook dentistry type stuff. So thank you for that. I didn't even think to ask you that question. But again, thanks for having me. Thanks for being on the show for me. I appreciate it. Everybody here watching this, I hope you learned something. If you know somebody that's on a blood thinner or could be on a blood thinner, maybe having some dental surgery, please send them this video. Have them ask us questions or learn, or hope somebody takes something away from this. So thank you so much. Have a good one.
You're very welcome. Have a good evening.